What about, so you raised, what about a non-dopaminergic therapy for, off time, right? So now we have istradefylline approved in the United States, which is a, non-dopaminergic, working on the A2A pathway, releasing that brake on the indirect pathway. So that's a way, once a day therapy. So I think for many patients that may be, an option as well now.
Yeah, looking at the clinical literature on that, patients who are often on multiple medications taking istradefylline as a therapy have enhanced their on time despite being on all the other therapies in those studies versus placebo. And once-a-day therapy using sort of a standard dosing is appealing for the ease of therapy. We still await the rollout of this drug so that all of us can start to get clinical experience. The last U.S. studies were published in 2008, so this is a newcomer to the scene, even though the medical literature requires going back, at least in the U.S. and European studies, more than a decade. The Japanese studies were 2013 completed, so it's a new drug, but
there's a lot of safety data also available because they have been around in Japan for a while. And the other thing is, if you look at the data as far as the safety is concerned, it's much better tolerated than some of the other drugs. And unlike MAO-B inhibitors, there are no drug interactions that we have to be
right. And I think you can take
about.
away from the studies that the effect is fairly rapid in onset, so it isn't a 3-month trial to see if your patient is doing better. And it's appealing also to not even have to think of pharmacokinetics or other interactions. It's sort of an all or none effect that istradefylline offers.
It also offers this non-dopaminergic, no side effects of dopaminergic side effects. So we tend not to see sleepiness. There seems to be only rare reports of compulsive behaviors.
Nausea.
Orthostatic hypotension is not seen.
Dyskinesias, I think, are about the only thing that might enhance. And of course, what do you do with dyskinesias? You lower the levodopa dose.
Right. So. And then not only istradefylline is approved in this country as a non-dopaminergic therapy, we also have amantadine, both the immediate release and extended release, and then the bedtime high dose that's been approved for dyskinesia. It also helps off time. So glutamatergic mechanisms is also a rational way of thinking about.
And the fascinating thing to me is it improves off time in patients who are on all these other medications in the studies. So it's a unique additive effect or synergistic effect. So it isn't one choice or the other. Going back to the notion of polypharmacy sort of makes sense if you read into the studies and what patients have been tested with. They've been on a lot of different drugs, but they do better. And then the question is it worth it in terms of cost, side effects, complexity?
So to me, the big interesting part with the amantadine ER at bedtime studies were, like you said, not only did it reduce off time and dyskinesia, being the only medication we have that reduces off time and dyskinesias, but the other interesting part is when we look at studies which we study drugs for off time, patients have 6 hours of off time. But when we look at a drug for dyskinesias, patients only had 3 hours of off time. And in spite of 3 hours, we were able to reduce it by 1 hour. Now, whether that is because these patients were more optimally treated, whether the drug had unique non-dopaminergic effects, we don't know. But it brings up an interesting point that every patient out there doesn't have 6 hours of off time when they get in a clinical trial. I think those are the ones which are really undertreated. If we are treating them adequately where the dyskinesia is an issue, their off time is also less.
It brings up this idea. We talk about patients who have dyskinesia, and we talk about patients who have off time. It's the same patients.
Right.
And our patients who have off time at a certain dose of levodopa will invariably have dyskinesia often. And those with dyskinesia at a lower dose will have off time. And we're focused so much on this balancing act, and these non-dopaminergic therapies and these infusional therapies give us another way of addressing the symptoms.
So, I think another thing that many clinicians may not be aware of is also probably sometime in the next year or two in the U.S., we may have another COMT inhibitor as well as a once-a-day therapy, which could also help us treat off-time